how excited I am that you're joining us tonight about a topic that I think is really, really important. What I'd like to do is really focus a little bit on what really all brought us here. Many of us know that acute care therapists have a responsibility to practice at the top of their scope to make sure that people are safe within their care. And I've been seeing just a few questions about how that applies to the maternal population with regards to monitoring their vital signs and making sure that they're also safe in our care and able to return to their environment and do more challenging tasks than maybe our normal patient populations do in acute care, which is taking care of a baby right after they leave the hospital. And then also taking care of themselves, as we really aim as acute care therapists to enable our patients to do with less risk for returning to the hospital. And so without further ado, I wanted to tackle this question um, more with a presentation on some of the information that we have available to us as acute care therapists. And I think that starting with a really amazing guide and getting into that tonight will also add to our defense of why we practice the way we do, if that's ever come into question, especially where it matters the most, the courtroom, that really a lot of us aim to protect our licenses. We aim to protect our scope of practice. And it's always a question of, are we actually practicing malpractice, which is to prescribe interventions without doing a proper assessment? We know that we cannot improve upon what we do not measure. And vital signs are a crucial component to that, is that we can't really improve someone's response to activity or their vital signs response or physiological response to activity, especially in the acute care setting, if we actually don't measure their vital signs response to that activity. So it's very important that we start there with this topic on vital signs and the responses that we're measuring to activity on the maternity unit or anywhere else in the hospital. This is the inaugural Women's Health Research Club. I've been really trying to get together a lot of resources that are helping therapists who are filling a special gap period of time where our patients will be sent home without resources after, say, a major abdominal surgery like C-section or a pelvic surgery that's deep within the pelvis, like a hysterectomy. And they're often waiting weeks to maybe months to be seen after those major surgeries. So I've been really working, and this is a project that's really come together now over about 3-year period of gathering these resources, getting the best data that really supports what the role of rehab should be within that gap period. So we're really looking at that special gap period of about the first 6 weeks after major surgery, after procedures, after birth, that may tax someone's cardiovascular, cardiopulmonary, other systems in their body and really reduce their mobility at first, just reduce their ability to oxygenate their organs to perform the activity that they want to perform. And so we're really looking at the role of research and the role of research in our practice, right? And championing evidence-based practice to be available within the field of women's health to really guide our practice as rehab therapists who are hoping to improve and enhance the quality of life of these patients. And so I can't go further without actually acknowledging the people that I think are the reason why. You know, why this topic? Why are we talking about vital signs on the maternity unit? Why are we talking about women's health in this gap period of care between the time that they have a procedure, with whether that's a C-section or whether that's a large perineal tear repair or whether that's hemorrhage or some kind of complication, and until the time that they are historically or traditionally referred to rehab. We're addressing that tonight with this topic of rehab in the hospital after birth and our role in occupational and physical therapy. I will say that it's important that we just address that there's acknowledgments that need to be made. And I am starting to do this now whenever I am presenting on a topic like this, because there's a lot of reflection that I've had to do on my own practice of being in outpatient women's health, working in oncology, working with patients who were admitted to hospice care, but still advocated for themselves and they wanted physical therapy and occupational therapy to be involved in their care to the very end. I've worked with patients both at the end of life and also at the beginning of life. So in the hospital after birth, after C-section, after vaginal delivery. And I've often reflected on patients that I just knew that there probably was more that we could have done, but we didn't get to have that opportunity. And so I do want to acknowledge three individuals that I've acknowledged in other talks, starting with Shantice Hollins. Shantice was a 22-year-old mother of three, and her estimated death was on January 4th, 2024, 2 days after her birth of her third child. She was found deceased in her home, and her children were in poor condition. Her newborn was found dehydrated, but from this source, was found that they were alive and were able to at least be stabilized at the time of this posting through GoFundMe. And so I do want to acknowledge that we, through Pelvic Health Network, who's hosting this webinar tonight, we're very active on sites like GiveButter, GoFundMe. We're constantly just finding ways to support not just the maternal population or not just through pelvic health uh, avenues or women's health organizations, but also those families that are left behind when care vehicles like the one that we've built could not reach them in time. And so we're very active on those sites. And this was sent to me from an acute care therapist who works in Oklahoma and who's trying to expand services for patients that are on the maternity unit of her hospital. And she sent this to me because of the networks that were discussing this mom and her family. And so as we're talking about vital signs on the maternity unit and why, as rehab therapists, should we be practicing at the top of our scope in our license, I would be remiss if I actually didn't think about the people that really inspire me to do this kind of work and to advocate for the highest level of practice when these individuals are in our care. The next person that I've acknowledged before, and I have to say, I really am touched by her story because this was sent to me by my best friend, Pamela Daniels from New Jersey, who is actually on the cover of the Acute Care Obstetrics Rehab Manual that we have been developing over several years, and we keep revising it. Every 6 months or so, we make a big revision. And Pamela, also in New Jersey, shared with Pelvic Health Network her own birth story. We professionally filmed her interview, and you can find that recording on our YouTube channel under Pelvic Health Network. But she sent me Drea Austin's story, and this was a 30-year-old mother of two. Her death was July 23rd, 2024, and this was 2 weeks after her birth, where she died of a pulmonary embolism that unfortunately traveled to her heart very quickly and stopped activity to her brain and the rest. In a very short amount of time, within 24 hours, she was declared brain dead by the time she arrived to the hospital. So this really hit me because we do a lot that we can in the acute care environment to, discuss positioning strategies, mobility, things to keep circulation. But there are some individuals who are on special medications, right, to reduce blood clots that have to be taken off those medications so that they're not at risk of bleeding, especially if they are expecting to deliver. And in Drea's case, apparently she was not guided on when to restart those medications soon after she delivered. And unfortunately, this was a preventable death. So her story was shared through the perinatalequity.org advocacy. And we know from the culmination of data from maternal mortality review boards across the country is that now we have 80% of maternal deaths are known to be preventable. And so if we on the rehab side of things can be a part of that team that so desperately really needs to have more robust assistance, the amount of providers in terms of ratio to the patients that they're treating is far less than other high income nations. We actually have the highest ratio of patients to provider, which is not a good thing. We need a low ratio, meaning we don't need to overburden our providers with so many patients. But if we as the rehab workforce can reduce the amount that's on the providers, perhaps Drea Austin's death could have been preventable, and the doctors had more time to assess her situation individually and restart those medications in enough time before she succumbed to a pulmonary embolism, which was preventable. And lastly, we want to acknowledge Morgan Hughes, a 23-year-old mother of twins. Her death was December 28th, 2024, and she died, unfortunately, of cardiomyopathy 9 days after birth. And most of you know this, but cardiomyopathy can be diagnosed up to 12 months after birth. But unfortunately, this was a case that occurred very soon. And her babies at the time were actually admitted to the NICU. And so a lot of times when we're talking about our role on the maternity unit, we're also considering those moms who have babies in the NICU. And once mom is discharged and their babies are still in the NICU, you have to think that, well, if they just gave birth, usually someone's pushing mom down in a wheelchair to see her babies. But once she's discharged, sometimes that support, that same robust support, is not available. So in Morgan's case, we don't know her situation, but we don't know if she was walking to the NICU from wherever she was, or spending a lot of time with the babies, or just after a twin birth, how much her cardiovascular and cardiopulmonary system was working. If we're questioning our role in terms of monitoring vital signs, we're really missing big opportunities to assess individuals in the context of their environment and in the context of their activity and just in the context of their unique circumstances. And so this is not more of a question of should we monitor vital signs on the maternity unit. I think that just the acknowledgement section alone of this webinar answers that. It's really how do we do it to the best of our ability with the information that we have? And so much information is lacking still about what is normal and what is not in terms of perinatal health, which is why, as Dr. Catherine Sylvester often advocates, we must use individual data, the data of that individual, and compare it with itself. Because so much of our norms and so much of our protocols for the general population falls outside of what might be normal for a person in like Morgan Hughes, for her situation, where she's young, she's healthy, but she's now a mom, and now her system is working the hardest it ever worked in order to regulate itself as she's trying to be the best mother that she can be. And her story was very touching. It was over several news outlets. The story was in depth, also shared from the family on GoFundMe. And we were a big supporter for her family to get the help that they need. So please, if you do have a chance to just take note of all of the links associated with these stories, please do your part in supporting these families, because really a lot of the help that they'll need is really after the tragedy has passed. With maternal surveillance, a lot of the evidence, if you will, that we used in my hospital settings that offered occupational and physical therapy to patients acutely on all units, but especially on the maternity unit, we were going by a lot of the indicators that are listed on the CDC, and that's severe maternal morbidity indicators. And so we weren't using maternal death to guide our practice. We were using maternal morbidity, which are those severe, either acute or long-term complications as a result of pregnancy or birth that can affect an individual weeks or up to years after delivery. And what we wanted to do really is reduce risk, and that is general acute care, right? Our goal is to reduce risk in populations, risk of readmission, risk of any kind of injury or illness that might be secondary to the reason why they're in the hospital, but then also just address the complications that people are dealing with now, which affects their mobility, which affects their hemodynamic stability, which affects their mentation and their ability to cognitively care for themselves or care for other people. And they're just their overall quality of life and what gets in the way of them maximizing their function of whatever they were able to do before they came into the hospital, and really making sure that they can transition to the next place, whatever that discharge location is, and continue with the care that they'll need. And so our goals with the maternity population are no different. These are indicators, just some of the indicators that the CDC has listed that we really should be more aware of, which include postpartum hemorrhage, so those individuals who have sustained blood loss to the point of needing a transfusion, hypertensive disorders. And so those individuals who have abnormal blood pressure, either response to activity or at rest, if they had a prior diagnosis of preeclampsia, or maybe those hypertensive disorders put them at risk for eclampsia. And again, we cannot improve what we do not measure. So this is not a webinar about whether or not we should be monitoring vital signs on the maternity unit. It very much is a capturing the opportunities that we have to prevent further morbidity in individuals who might be at risk for these things or who have been diagnosed with these things. And so these are the things that we would want to prevent, and hypertensive disorders are a big part of that. We'd have to measure those vital signs to actually know if hypertension, which is asymptomatic in most individuals, is actually present. Thromboembolism in PE, like Drea Austin's case, we would want to either monitor signs and symptoms of a person having an issue with a clot, or if they're getting up for the first time with us, or maybe doing a little bit more activity, maybe they're getting out of their room for the first time, or they want to try to walk a longer distance, or they recognize, hey, my home is actually on a third-story walk up in my apartment. I'm going to have to be able to go up and down stairs. And now they start coughing, or they have chest pain, or they're getting short of breath. We have to be able to monitor their vital signs to catch something like a PE or an embolic event, infection and sepsis, knowing that their heart rate could be abnormally high in those situations, or maybe their SpO2 is off via oximetry. Have to be measuring in order to catch whether those vital signs are off. Acute heart failure, pulmonary edema, cardiomyopathy, stroke. Again, in Morgan's case that we just discussed, the mom who died 9 days after her birth, I would hope that someone was actually taking into account the home that she would be returning to, but then also the activity that might have been involved with her going back and forth to the NICU, right, to visit her twin babies. I would hope that someone was actually monitoring her vital signs, not just at rest, which we know is routinely performed on the OB unit by nursing, but also during the activity and immediately after performing that kind of activity, once she sat back down, and we could get a holistic 360 view of how she responded to the activity that we put her through. I would hope that we would do that for the very sake of knowing that as occupational and physical therapists, our role on the maternity unit is to be more on the quality initiative side, making sure that our care is the best that it can be. We are not working, a lot of us are not working in high reliability organizations, even though we want our hospitals to be that way, but they are not as strict as, say, nuclear plants, where we know that those protocols are to the T so that a nuclear bomb isn't released, right? We know that our hospitals are just not there. But we as occupational physical therapists have a role in making our care as robust as possible. We have to think about all of those leaks, if you will, or opportunities for error to be made and try to tighten up those errors. And to do that, we have to understand what risk is involved that we want to reduce. And the risk in the acute care environment, primarily associated with birth, are mostly the day of delivery and in the first 6 days postpartum, where individuals, the most common cause of their death are hemorrhage and infection. And so we know hemorrhage is a big side effect of cesarean delivery because it's an open abdominal surgery. The abdomen can be open for an extended period of time. The surgery can last up to an hour, sometimes more or longer, especially if there's excessive bleeding. It could turn into hysterectomy. And it can lead to infection and other complications, respiratory function. We know that that is related to secondary complications like restrictive lung disease, which could affect the amount of oxygen that a person can get into their system. So we know all of these things can snowball on the maternity ward. And so as occupational physical therapists, we have to really think of, well, what is our scope of practice is to return that person to, as best as possible, a more ideal discharge location so that they can continue recovering and optimize their ability to thrive there and not be readmitted back to our hospital. And so in order to do that, we do have to measure those vital signs that may indicate there is still something going on after this big surgery. Maybe there's more risk for hemorrhage or internal bleeding that we haven't noticed yet. Maybe the heart rate is getting a little bit higher. Maybe there's shortness of breath. Maybe there's unusual pain at the incision site. That's even more abnormal than what should be there with mobility. Maybe there's something wrong, and vital signs are our one of our important tools is primarily for data collection. It can indicate that there's an opportunity to reduce risk if we are actually a part of the maternal surveillance team. So do take into consideration that our role on the acute care side of maternal health is to reduce risk, but it's also to be quality proponents and be part of the maternal surveillance team. And so what our eval is including, and we're assessing vital signs in our evaluation, and this is general acute care practice, but it doesn't change when that person is either seen in the ICU, when that person is either seen for a general trauma, a fracture because of a fall, a stroke, a blood loss from a major procedure, from a gunshot wound, or if they had a baby. That's the beauty of acute care. I think that's what drew me as a women's health therapist that worked in oncology for the most of my career, is that when I transitioned into acute care, there really wasn't room for um, neglecting someone's needs. I couldn't just choose to not see a patient because I just didn't, believe that homeless people needed rehab. It wasn't really room to actually discriminate against individuals. It didn't matter if that person were in the hospital for a major traumatic event or for an elective surgery. I was going to be able to see them, and I was equipping myself to see anyone who walked through the door. And so an evaluation is an evaluation. And our practice is to assess that person's response to activity, that person's ability physiologically to handle the demands of the tasks that they're wanting to do when they return home, they're expected to do, that they need to do. And so with occupational and physical therapists, we're working really to assess globally if that person is safe to discharge to A, B, and C location. And what do they need? If they're not, what do they need in order to be safe, in order to be successful with that discharge plan? And so on the physical therapy side, we're using a lot of measures that involve basic mobility, and that's getting out of bed, that's transfers, that's walking, that's stair negotiation. And with the OT side, you're looking at activities that that person is engaging in every day. bathing, dressing, toileting, hygiene, also newborn care, caring for other children at home, maybe caring for parents or a loved one or a pet. And then also just home management, whether they're able to prepare food or manage their medication or do the household tasks that's associated with what they need to do. And you can get higher and higher and broader with those definitions. But in acute care, our role in the maternity unit doesn't change, not one bit. We're using the similar outcomes measures that we would use with other patient populations, and we're measuring their vital signs. What does change is really looking at certain outcomes. And that's where I say using what we use in general practice is really important with the maternal health population because we're looking at their outcomes, but then realizing, man, that does actually change in the context of this person's environment. Well, what do I mean by that? Well, if a person has an open abdominal surgery, an exploratory laparotomy, because of something affecting their organs, they need emergent open surgery. We are typically looking at individuals where they don't have extra demands of caring for a baby. And so, or they weren't pregnant before. So, in our general population, when we're looking at the adult vital sign interpretation and acute care guide, that was really meant for general populations, but had considerations for special populations, maybe those individuals who are admitted to the ICU or those individuals with a spinal cord injury. What we want to just really remind ourselves is that what makes the pregnant population, postpartum populations really unique in acute care are their contextual factors. And that's their personal, and that's also their environmental factors. What are they returning to? And then the amount and demand of the activity that they're expected to do really soon. So their surgical precautions, we may actually approach that as an abdominal surgery patient, looking kind of apples to apples, but that means little to nothing, not lifting more than the weight of what, 5 pounds, 8 pounds, 10 pounds. That means nothing if that person is a single parent and they may have an apartment on the second or third story, and they may need to carry their baby in a carrier or be going up and down those stairs or going to the first pediatrician visit within the first week. And so that's where our acute care outcomes really needs to be specific on the maternity unit to those contextual factors, the personal and the environmental factors that our patients are returning home to. Not to say that that also doesn't apply to someone after a spinal cord injury or stroke or whatever. I just treated recently a 92-year-old individual after a shoulder surgery in the hospital who was adamant that, they wanted to return home. They lived alone and they were independent before this. And that was really tricky situation because there was so much about that case where that individual was not safe to return home. And so we're doing that with every single patient population, but we have to also just kind of really take pause to understand that the vital signs that we're measuring, we're having to consider that there was already a change with pregnancy and that there's more of a change after that person delivers, and it's very individual to those people. We know that in pregnancy, blood pressure is actually supposed to get lower. And we just had a quiz in our enhanced recovery after delivery group. We just had like a kind of a spontaneous quiz where we asked the question during pregnancy, does blood pressure increase, decrease, or stay the same? It was something along those lines. And to my surprise, these are occupational physical therapists. Most of them got it wrong. And it's because I think that we're kind of, we almost think that, well, with an increased blood volume in the body during pregnancy, we would think that the blood pressure would increase, but it's the opposite. It's because of the increased volume and the decrease in peripheral vascular resistance that our blood pressure actually normally dips. And its lowest point is in the second trimester, around 23 or 20 or 22 to 24 weeks or something along that lines. And so I think that maybe therapists have been conditioned, at least in that group, at least at that time of the quiz, to think that blood pressure increases. And so if we see a few degrees above their pre-pregnancy normal, if we know that information, we think, oh, not a big deal, where it is actually a big deal if we're seeing that in pregnancy. And then what we have to know is that postpartum, what should that look like? And so knowing the norms is really important. And so using a guide that's for general adult, there might be some like confusion. Well, why isn't there a guide for pregnancy and postpartum? Well, there isn't. There's studies that have been done in the UK or in Europe, but we don't have definitive guidelines of, hey, this is what we need to go by in order to know if this person is outside of their norms, which is why we're really advocating that you measure that person's norms against themselves and taking into consideration the context of their activity. All three of these individuals in the middle were tremendously different from each other with the amount of support that they had, with their age, with the number of children that they had before, with maybe their delivery types, with the context of the activity that they were doing immediately after delivery. And so I can't say, yes, all of them should have been blood pressure wise between 115 over 83 or something, along those lines to 124 over 76. I'm completely making that up, but I'm looking at ranges of what we might consider normal in the first 2 weeks postpartum. And I'm telling you to take that with a grain of salt because you have to measure it with the outcomes and the contextual factors of those people. It's incredibly important that you get this point, is that you could have a range that is normal for any person. And you can know as an acute care therapist that when this person is doing this met level of activity, that's the metabolic equivalent of tasks, and they're changing from lying in the bed to sitting up to standing to walking to showering to doing stairs, I should be seeing maybe 10-point increases in their blood pressure. And I'm telling you, use that information versus this protocol that you think exists for the general population or for the postpartum population, and these numbers that should be for everyone. I'm telling you, you're probably not going to see that. You're not going to see that someone's going to be fitting neatly within that protocol. It's important that you measure that person's norms against themselves, and you take into consideration their surgical precautions, the demands of their life at home, their personal care, and the confidence that they have doing all those things that they need to do to care for themselves, the confidence that they have with caring for their baby, the support that they have with taking care of their household, and the support that they have also with caring for their baby. And so the considerations for the adult vital sign interpretation. Wrapping up, I want you to know these considerations from the guide, is that vital signs at rest help determine readiness. This was a guide meant for physical therapists, but please, occupational therapists, I know you're in the room and you're wanting to know how this guide applies to your practice, but this was a guide that was meant to help determine readiness for PT intervention. And those are the interventions that involve bed mobility, transfers, gait, stair negotiation, heavy lifting activities. But I would say for occupational therapists, showering is one of the most demanding metabolic tasks that someone can do. Regulating their body temperature, especially in the setting of postpartum hemorrhage, is extremely taxing on their cardiopulmonary system. So really think that these vital signs at rest help determine readiness for OT and PT intervention in conjunction with other findings. Remember, sometimes we also don't need to remind ourselves of this on other units. But it comes up on the maternity unit is, well, should we be taking vital signs with someone who's on blood pressure lowering medications if they're having a hypertensive if they're being managed hypertensively. And we assess vital signs regardless, right? We're still getting a picture, but we're taking it into the context of just understanding, yes, that that there's going to be factors, including medication adjustments, things like that. But even this last bullet point answers that question. It came up, and I'm laughing because during the talk, I was just like, well, of course, we still should monitor vital signs for adverse reactions, especially during medication adjustments, transfusions, or other procedures. Middle 2 points, we should, during interventions and recovery, we should be assessing hemodynamic and oxygenation responses and stability. Also from the guide, PT providers, I would include OT providers, should follow your institutional policy and procedures, not regarding vital signs, but regarding activity. And I would even venture to say that this may mean activity outside of the room. This may mean that if the patient is actually on telemetry, are you able to take them out of the room or into a stairwell where you might lose that connectivity? And so do follow your institution. If you have to do stair negotiations where you're going to have to modify your plans for the activity and maybe bring a step stool into the room, but no way in shape or form does this say PT providers or OT, I would say venture therapists in general in the rehabilitation profession should follow the institutional policy regarding vital sign assessment. It doesn't say that. It says regarding activity. So it's really part of our practice act as rehab therapists and providers to evaluate patients. And in order to evaluate patients, especially in the hospital and acute care, we have to evaluate their response to activity. And in order to evaluate their response to activity, well, we actually have to measure it. We have to measure vital signs. And so that's a really key note coming right from the adult vital sign interpretation in an acute care guide. I love this guide. It is so rich and so dense and even packs even more information that I really have taken and used to educate physicians and educate nurses on my role on the maternity unit and my role really anywhere else in the hospital. Normal activity response. So we talked a little bit about this, but in the guide, pulling from their section on blood pressure, what we should normally see is that systolic blood pressure increases 10 millimeters per mercury per metabolic equivalent. Hypertension is generally asymptomatic. So symptoms should not drive the need for vital signs assessment. So let's just talk about those two bullet points. So systolic blood pressure increases 10 millimeters per mercury per MET. So that means MET is, I would say, the consumption of oxygen to perform an activity. In general terms, if you were explaining this to a loved one or a friend, what are metabolic equivalency of tasks? And it's the energy that our body is using in form of oxygen to perform an activity. And so someone who's lying down and moves or transitions to sitting or moves and transitions to standing or moves and transitions to walking or then does some type of activity, stair negotiation, well, they're increasing their MET level to running, to showering, all of those things. And so we should normally be seeing an increase in blood pressure. Hypertension is generally asymptomatic. We mentioned that before. And so we're not waiting for someone to be diagnosed with preeclampsia. We know that preeclampsia can be diagnosed within the first 12 weeks. I used to say 6 weeks because that's what the literature was supporting. But we have literature that's looking at 12 weeks after birth that people can still be at risk of being diagnosed with preeclampsia. So we don't wait for those symptoms to arise. We measure vital signs. Inaccurate pulse oximetry readings often occur with dark-skinned individuals, with Black patients more likely to have false high readings than white individuals. So even more so, if you have an individual who's a dark-skinned individual after birth, who's a Black woman after birth, do take into account your pulse oximetry readings may not give you an accurate finding. And so that should be really assessed along with other findings. You know, their heart rate. You should be looking at their rate of breathing, respiratory rate, their difficulty with breathing, if that's present. And then major surgery is a risk factor for complications such as sepsis, such as respiratory complications or failure, such as abnormal blood pressure. So assess these vital signs during that person's eval, especially if they had a hysterectomy at the time of their birth, if they had a C-section, open abdominal surgery, if they had their tube side, if they had, any longer procedures, perennial wound laceration repair, anything like that. You monitor their vital signs. And so, really, just to kind of tie all of this together, the Joint Task Force of the APTA, Acute Care, and the Academy of Cardiovascular and Pulmonary Physical Therapy, this webinar really is uh, cannot thank them enough for creating this guide that's really meant to guide acute care therapy practice with our patients, with adults in the hospital that include the maternal population. And I reached out to contributing authors of this guide because it was just out of curiosity, just to see what their thoughts were. Was this guide meant to exclude patients after birth? And it was absolutely not. It was meant to be inclusive of all of our populations who are seen for any reason during their hospital stay, and then especially in the days after while they're recovering before they return home. And so it's very important that we give credit to these two academies of APTA who worked in putting this guide together. And I think I might have counted, but this guide uh, has about 152 references. So if you really need any resources to support your practice on the maternity unit as an acute care provider, OT or PT, please use this one guide. Is really a culmination of all of these the articles and the amount of resources that they've pulled together to really support acute care practice is by far one of the best resources that I've come across, and has really helped me to educate nurses and physicians on every unit of the hospitals, but especially for patients after birth. With Pelvic Health Network, again, we are doing a lot of mission-focused work. And so please, if you can, subscribing to our YouTube channel, supporting the interviews that we're doing. Our goal is to really interview mothers directly. If you feel that, your hospital is giving you a lot of pushback, they don't support OT and PT practice on the maternity unit, they're saying that it's not necessary to measure vital signs, then I would say it's not worth your license. Back off. The work that I think a lot of us are doing inside and outside of the hospital will stand to support rehab um, during pregnancy, during high-risk pregnancy, and immediately after birth, and really bridge the gap of care that we all see, which is the 0 to 6 week time frame of these individuals just really being told to manage everything on their own. Maybe they're given one visit, maybe they're given one visit at the 2 week mark, maybe they're offered telehealth services, but maybe not in these rural areas that we know are maternity care deserts, and maybe not in terms of the activity that is really important to the context of what they're doing. Maybe they're not given a lot of guidance on actually what they should be doing or should be avoiding. And that's really where we're working. But to me, we're approaching evidence-based practice pretty plainly. We're using the best available data to fit the unique values and circumstances of our patients. And so if you're being told to not monitor vital signs and that's against your practice, it's against your scope of practice, it can put your license at risk, I would say I would step away from that unit and not practice on that unit, because you're putting your license at greater risk. If you were to then prescribe interventions for that person and you haven't assessed their response to activity, I would not want you treating my family member. Just plain and simple. I think I've seen probably too many patients be readmitted specifically after a cesarean section infection that then required an unusually long stay, a lot of morbidity with that individual, a lot of pain, lost time, lost money. It affected their financial future, affected their relationships, all of it. And I've seen individuals also, or at least worked with PTs and OTs who have worked with individuals admitted to the ICU or readmitted to the hospital because of uncontrolled hypertension, preeclampsia, brain bleed, stroke. There's just so much, I think, with this population that we can do to improve it. But to me, if you're not assessing vital signs, and you are afraid more of what the nurse or what the physician wants you to do, you're not practicing physical or occupational therapy. You're practicing as a technician in their medical field. And so if they need technicians, there's plenty of people that can do that work. But as an OT and PT, you're doing an evaluation that someone without your license cannot do. You're doing an evaluation that only you can do because you're assessing the person's demands for their activity. And so instead of really going to our hospitals for answers that may have their own policies, we're really using the evidence, the best available evidence, and the patient's story in the context of their activity to guide our practice. So I would say keep your license, get off that unit, and do more work on the outside so that that patient really has more of the support that they need within the first 6 weeks. But thank you so much for your time, and I really hope that this was helpful. All right. Thank you so much all for joining us live. Just a few minutes. I would really like to know if you have any questions. Definitely, I'll look through the chat. But in terms of just the research work that we're doing, if you have any really just anything that you've been tracking in your hospitals, I would love for you to let me know if you're willing to make that information available. We're working with a surgeon who had automatic orders when I was practicing in 2020 for physical therapy after a cesarean hysterectomy. And she is now doing a multi-center research study on the actual benefits of offering occupational physical therapy in the hospital after birth. So she's asking for data. And really, if right now we're in such the beginning phases of this, but if you have data that you've been tracking, like vital signs or like readmission rates to your hospitals that you'd be willing to at least share in terms of what exactly you've been looking at in your own institutions to know if there's been a benefit, please definitely reach out to us. The same avenue that you took to join us tonight, but we're really active in our enhanced recovery after delivery group. You can reach us on through email, through info@pelvichealthnetwork.org. But if you're willing to basically give us kind of the criteria that you've been using to provide OT and PT on the maternity unit, we would love to know what have you been using, what's been helpful, and that's really just to support the research that we're doing. And so this is really more of a beginning for women's health research, clinical research that can help to inform our field of providing rehab a lot earlier to this patient population after birth, after major surgery. So I would really love for you to let me know what you've been collecting, and I will absolutely reach out to you. But please stay on if you have any questions or you'd like to chat. But I will be keeping a lot of these notes that you guys have added to the chat, and I can't wait to connect with you about some bigger projects that we have in the future. Awesome. We had one of the contributing authors of the guide. I don't know if she's still in the room, but Dr. Catherine Brito, thank you so much for joining.
Shout out not necessary, but appreciated. I will say, that resource list that we cited is long and it was a labor of love from all the members on the joint task force, but yeah, I consider it to date probably one of my greatest achievements of my career to help write that guide because of how many different areas of practice and how many people it's helped support their ongoing practice. So, really great to hear that from you, Rebecca. I really appreciate it.
Would you say, just short commentary, that it was ever meant to exclude the maternity population, just for the record?
No, not at all. I mean, when we did specialty populations, we kind of factored in the 80/20 rule at the time of what was the most common and what were people seeing the most, or what did we have the most evidence for evidence to your point, what did we have the most evidence for at the time that we could um, put into writing a comprehensive guide? I mean, as you said, there's over 150 sources cited in this document, and I think the only reason you would see a population like this specifically had omitted at the time was just due to lack of evidence, but also lack of consistent practice, which I think kudos to you. You and your colleagues have been leading the charge on this and have really created such a movement within acute care physical therapy. So I want to thank you for that. But you are correct. It was never meant to omit any specific population.
Thank you so much. Yeah, no, thank you so much for the record for saying that. And thank you so much for the kudos. Also, Carrie, would you like to ask your question? I'm reading it,
Sure,
but I mean, while we
I can
have,
ask it. Yeah.
yeah.
So, hi, I'm Carrie Gillenwaters. I'm an occupational therapist, and I serve as the director of support and community engagement for a Solace Foundation, which is for severe obstetric anal lacerations during childbirth, or just any kind of severe obstetric lacerations that we talk about. Um, One of the things that I wondered is when we're looking at vital signs and what they indicate, when we think of all the systems in the body that they correlate with, I'm wondering if any research has been done about use of vitals to also consider assessing felt sense of safety in care. Because one of my thoughts that I have around tears is that I question if when people do not feel safe in the care of their providers, if they have difficulty um, going through the labor process, and if that is also contributing to the higher number of lacerations. I don't know, but I'm also curious if when blood pressure is high prior to birth or at any point, if anybody's measuring that, and measuring that is not just the physical components, but does there seem to be any kind of correlation with self-report of not necessarily feeling safe with their care providers and how
I
that
would,
might with outcome.
and you probably know this person already, but Dr. Sabina Khan, do you follow her work?
I'm trying to remember. That name sounds familiar. Yes.
She's an occupational therapist, professor, was just recently recognized the first occupational therapist to win a pretty prominent award, but has been doing lightning speak, trailblazing work in maternal health. Has worked with maternal mental health, um, to more of the early interventions that occupational therapists can provide, but then also just looking a lot at the care of this population in general. And to me, that's an excellent question. I'm not sure if you're active on LinkedIn. There's so many ways to get
Yeah,
in
I
touch
can
with
reach
her, but
out. Mm-hmm.
I would say that is your go-to person
Okay.
for, at least if it's not being done, proposing that a study like that be done, because I completely agree how often are our vital signs being skewed by our sense of safety,
Right.
especially with under those conditions. I think that's an
Mm-hmm.
excellent question.
Okay. Thank you.
Dr. Catherine, thank you so much. So, in response, Carrie, to you, stress contributes to elevation of heart rate, elevation of blood pressure. I'm sure there is a correlation on how that affects tissue health in high stress environments. With the high stress being what you described, these are individuals who had um, birth complications or traumatic deliveries. And so, yeah, I mean, I cannot wait. For that research really to just more research, especially with mental health, to be done with this field in conjunction with rehab. So great questions. And thank you so much really for all being here, for participating. I hope to have more forums like this, but would really love your feedback on what you would like to know, what you would like to learn. This was inspired by a therapist who had a little bit of pushback, and I just was really inspired to just say, if it's not really worth your license. These programs will start around the country, and soon it'll be a floodgate. But if you're having that much pushback to where you could not see this population because you still want to assess their vital signs, but the nurses and doctors don't want you to, I would say I would withdraw the program at that point, because you still have to practice at the top of your scope as an OT and PT. And so I mean that with the utmost sincerity. It's not worth your license. If that patient comes back, like in Genesee Grace case, my partner in crime in all things, but she had a patient that was readmitted within 12 hours of discharge after C-section. And we're still not sure if the therapist just didn't document it, but there were no vital signs documented when they did certain activity like practicing stairs that she had in her home. And so she was admitted and had to be admitted to the ICU, burr hole surgeries through her skull to relieve the pressure off of her brain because of the severe um, um, symptoms that she was having, obviously, and stroke, hemorrhagic stroke that she had experienced. And so she was admitted to the ICU and was cared for the duration of her hospital stay. So just think about that, is that if you're not assessing vital signs with activity, who is? And it's just not worth your license. So I hope that this was helpful and off to a good start for all of you who are building programs, but those of you hitting those roadblocks, it's just not worth it. Carrie, to answer your question, are patients ever being guided to take their own vital signs if not allowed in birthing unit? For example, saw a therapist prior to birth, if saw a therapist prior to birth or as part of a community birth class. I would say that most I would I would think, and I work a lot with midwives in the community, is that most patients are encouraged to know their own norms and their own data. And so on the maternity unit, I would hope, especially from nursing and from physicians, that they're also encouraged to continue that at home. They have to be, because they're often the first line of defense. A family member is the first eyes on that person to see if that there's something that's gone awry. And so, I mean, to answer your question, could OTs and PTs be doing that as education? Absolutely, but it does not replace practice. And I don't think that you meant that at all, Carrie, but that's kind of more of my concern, is that we still have to do an evaluation and bill and charge appropriately for something that we did do. And so an evaluation to me is just incomplete without that information. And so education on taking your own vitals just doesn't replace our evaluation. Well, thank you all. And I hope you have a wonderful evening. And please just reach out with any requests, questions, comments, feedback on more topics like this that you might want to hear.